Good morning. My name is Jeff Zobel. I am a clinical pharmacist at Children's Hospital here in Tucson, Arizona, but also a clinical support liaison for MVW Nutritionals. And it's my pleasure to do this training. It's recorded, but it's a training for all specialty pharmacies. And we're doing this specifically for your pharmacy regarding cystic fibrosis that you can use as a training for futures being recorded. So you can have this for training, but also information for future regarding the changes that are happening with cystic fibrosis here now in the new era of highly effective modulators. And so that is the purpose of this training we're giving to you. So the only disclosure I have is I'm a clinical support liaison for MVW Nutritionals, is a company who provides vitamins and probiotics for cystic fibrosis. So the objectives we're going to do is we're going to just kind of describe the basic pathophysiology of cystic fibrosis and the organs that are affected. We're going to look at the current evidence and future directions regarding the chronic medications in patients with CF in this era of highly effective modulator therapy. And then finally, the medication access programs are available for CF patients to help reduce their cost. So in terms of demographics, this is an updated information as of just released from the CF meeting a couple of weeks ago, that there's about 100,000 CF patients worldwide, both pediatric and adult, with over 40,000 being the United States alone. And one of the most impressive things is that now we've shifted from a pediatric disease more to an adult disease, where the percentage of patients now are more on the adult side than on the pediatric side, because the median survival for CF patients has risen up to age 56. When I started with CF back 17 years ago, it was around 28 to 30. And now it's basically doubled since the time I've been involved with CF. In the most recent release from the CF Foundation, from the new registry report. Both parents of CF patients have to be carriers of the CF gene, giving a 25% or 1 in 4 chance of having a child with CF. There's over 1,700 different disease-causing mutations, with F508del being the most common mutation, up to 90% of patients having one copy. And there's over 1,000 new cases diagnosed each year, most of them being newborn screen in the pediatric population. So CF, what is it? It is a genetic progressive disease that affects organs of the body, mainly the lungs, the pancreas, the liver. Those are the main things that we see that are affected. And it's affected by these mutations in the CF gene called the CF transmembrane conductance regulator, or CFTR. I'll refer to as CFTR for the remainder of the presentation, which leads to a non-functional CF protein channel. And that protein channel moves chloride across the membranes of cells. And we're going to think of it as a lock and a key. And so if you don't have any channel at all, there is no lock and key at all. Or if the channel doesn't work, and there's certain mutations that affect that, the channel doesn't work right, it's a rusted lock. And so the channel's there, just not working right. And we're going to go through the different mutations in using this kind of analogy to see exactly how these mutations affect the CF patient. So if you don't have CF at all, and you have your pristine DNA, and that makes a pristine RNA, which makes the channel, this pristine lock that you could buy at Home Depot, very expensive. It moves chloride ions effectively across the cell membrane, leading to attraction of water, because water follows the chloride or the salt ions, then leading to this pristine, thin mucus flowing throughout the body, kind of like a river flowing. And so it's clear, doesn't have any issues. However, if the CFTR is not working right or is not there at all, we have problems. And so the first of these mutations, and they're divided by classes, and there's class 1 through 6. A class 1 mutation is where the DNA and RNA have a flaw, which doesn't allow to have a channel being made. And this is considered like the G542X mutation is the most common. So anytime you see an X mutation in any of their genetic profiles, that's what we're talking about. And so because of the DNA having a flaw, the RNA is shortened and doesn't allow for any channel to be formed, which then no chloride ions are made or moved, no water is attracted, and then instead of having a thin mucus, you have this thick, sludgy mucus throughout the body. And think of it as a swamp. And this is what Shrek loves. And so Shrek lives in the swamp. This is what we happen throughout the body, the organs, this thick mucus clogging all of the channels and the tubes throughout the body, leading to the damage that we have. If there's a class 2 mutation with the F508del is an example of that, the DNA and RNA have flaws and leads to a misshaped CFTR protein. So with that flawed RNA, you have no channel at all, no chloride ions, no water, and you still have, and then you have the swamp again, but this is in more patients. And this is roughly 90% of all CF patients have this one copy of this mutation, leading to the thick, swampy mucus throughout the body. If you have a class 3 through 5 mutation, these are ones that are considered that the class 3 would be the G551D, and then a class 5 and 6, they're not as serious of mutations. These are patients who may have been diagnosed later in life. The DNA and RNA have flaws and makes a CFTR that doesn't work right. And so this is where instead of having no lock at all, you have the rusted lock. So it's there, just dysfunctional. And so either it doesn't have any chloride ions moving at all, like a class 3 mutation, or there's less chloride ions moving, and this would be your class 5 and 6 mutations. So there's still no water or less water, but you still get the thick mucus, you still get the swamp in these patients with these mutations. So this is what the swamp look like. You have it affects the different parts of the body. So you have affects at the sinuses, the salty sweat, and it affects the gastrointestinal tract, leading to acid reflux, pancreatic insufficiency, liver issues, CF-related diabetes, and then the lung issues, which is one of the most prevalent things that we see in these patients, as well as infertility in males. So what would a pharmacy talk be without talking about the medication? So the rest of the time, we're going to be talking about the different areas where medications have the issues and what medications exist in order to help alleviate some of the symptoms. So we'll start with the gastrointestinal tract. And so from the mouth all the way down to the bottom, there is CFTR that's affected all through this. And that's why we're going to talk about the different organs that are affected and the medications that we have. So the first of these would be pancreatic insufficiency. So the pancreas is cystic and fibrotic, and that was the original name of CF when they did autopsies on children. They found that the pancreas was cystic and fibrotic, and then the original name was cystic fibrosis of the pancreas. So this is where the original thing found that pancreatic enzymes were not being released from the pancreas into the intestines. And so you could test for this via a test called the fecal elastase, which when you get a measure is less than 200 micrograms per gram, or you have sensitive malabsorption, this is a consideration for needing pancreatic enzymes. And so the CF Foundation recommends that all patients, regardless of age, start on pancreatic enzymes, especially infants when they're first born and first diagnosed. Roughly 80 to 90% of all CF patients are on enzymes, and they all contain lipase, protease, and amylase, but they're standardized and dosed based on the lipase units. So when you see a prescription for Creon 12,000, that means that there's 12,000 lipase units in each of those Creon capsules. And so that's where that number comes from. And the reason we do need to give the enzymes and also need to take their enzymes is we need to prevent the issues that happen. They need that for the proper absorption of the nutrients, fats, proteins, carbohydrates, as well as fat-soluble vitamins to prevent symptoms such as steatorrhea, which is fat in the stool, and other gastrointestinal complaints, as well as appropriate weight gain. If they do not take their enzymes, they will exhibit some of these symptoms in and will have inappropriate weight gain. So we must give them their enzymes in order for this to happen and prevent these from occurring. The enzymes that are on the U.S. market, we have Creon, Zimpep, and Pancrease. They are very similar. They're little capsules within a larger capsule. They have amylase, protease, and lipase. All of them are very similar in how they're dosed and what they do. Viocase and Pertzy are a little bit different. Viocase is a tablet that can be crushed, and it's not in capsule form, and so that's what it's a little bit different. Pertzy has sodium bicarbonate in it. The original name for Pertzy was pancreacarb, and then when it was changed, the formulation was changed and FDA approved as Pertzy. It still has a sodium bicarbonate in it, so it is a little bit different than the other three previous ones. But it also the Pertzy 4s can be given through a G tube and FDA approved. So those are some of the differences between these enzyme products. There are no generic pancreatic enzymes available, but if they're FDA approved, and so we recommend that they only use the brand name products that are FDA approved for the patients. The dosing, as you can see, is based on lipase units. Usually, as they get older, the enzyme dosing for the meals are more than for the snack and for each age group. But the one thing we need to know is we need to make sure that they are not going above the 10,000 lipase units per kilo per day. That if you go above that, you can have increased risk of constipation as well as a condition called fibrosing colonopathy. So we do at clinic visits, they will make sure their enzymes are appropriate and then adjust if they need to prevent steatorrhea as well as malabsorption symptoms, but also prevention of having the issues with the overdosing of constipation, fibrosing colonopathy. Counseling points. So these are some things that you can look for, especially if they are younger, that each capsule contains many small beads, so you don't want to break or chew them. They're not stable milk or formula. So if you end up putting the enzymes, if the family opens them up in milk or formula for a baby, it actually can coagulate the milk and turn it into cottage cheese right in front of you. So you want to make sure that the enzymes are put into something like applesauce or acidic baby food to be given to a baby instead of the milk or formula. Once the baby has had the enzymes, you know, check their mouth to make sure there's any babies left in there because they can cause ulcers in the mouth. The only one that can be shipped, all the ones can be shipped in other containers to the patients except for the Creon 3000s. That one must be stored in the original container and shipped to the patient from the pharmacy. There is another product, the enzyme product that is on the market called Reliazorb. This is just for your information. It is utilized for patients for enteral feedings. It's a cartridge that contains immobilized lipase beads in it. As the tube feeds are given, it actually breaks down into hydrolyzes the fat into smaller components so it can better absorption. It's considered a medical device, not a prescription product medication. So insurance coverage is difficult for this for patients. And so not a lot of patients are on it, but this is just more for your information. And there is a copay assistance program available, and the website is down below. The copay assistance programs are available for Creon, Zimpep, Pertzy, and Pancrease. They all are great programs that help with the affordability of the enzymes, but also are value-added programs. So Creon program is available for all patients with commercial insurance as well as for patients with TRICARE. This is one of the differences between the other programs. TRICARE patients don't get the copay assistance, but can enroll in the value-added program only. The ones with Medicaid, Medicare cannot. This one allows for TRICARE patients to do that. They do have copay assistance for patients and provides no-cost specific CF vitamins, the MVW and DECA's lines, DECA's through Callion Pharma and the MVW complete formulation through MVW Nutritionals. They are available through this for the patients can go in and order what they need. It also provides no-cost nutritional supplements for the patients on a monthly basis. The ZEMPEP Live to Thrive program also is available for anyone with commercial insurance. Medicare, Medicaid, TRICARE are not available for this. The differences between this one and Creon is this also provides not just the DECA's and MVW complete formulation vitamins, but also MVW probiotic, and the Carlson's vitamin D products are available through this to order, as well as no-cost nutritional supplements through the Nestle line. The PERTC Care and EPI Nutrition Program, the difference with this one is the proof of dispense has to be submitted by the patient every month in order for them to get their products shipped to them. And so that's one of the differences with this one between the other two is they have to provide that proof of dispense. The Pancreas Engage program, this one, the benefit is not as much. They still get the vitamins and nutritional supplements, but they get a savings card that they can do every month and go into a online store and order the stuff. So sometimes patients may not be able to order both because of how much is on the savings card that they will get towards the online store to purchase the products. So throughout this, I've got clinical quandaries of what's changing in this new era using actual real-time data from the CF Foundation. And so clinical quandary number one is a nutritional clinical quandary, looking at the changes since 2019 in both weight, BMI, for pediatric and adult patients. And you can see since 2019, since the era of highly effective modulators when elexacaftor, tezacaftor, ivacaftor was released, you see this dramatic rise in the weight in both pediatric and the BMI in both adult patients. And the issue with this is, what are we going to do with this? So we've got right now, as of the most recent data report from the CF Foundation, over 65% of CF adults are now at the CF Foundation BMI goal. They've never had this before. And over 13% of CF patients are considered obese. We've never seen this in the history of CF. But also now we're seeing several case reports of patients converting from pancreatic insufficiency to pancreatic sufficiency. And there's several of those case reports listed here on the slide. So what do we do with this in this era as pharmacists and pharmacies taking care of these patients? Well, there was an article released by a group of CF dietitians back in 2022 that offers several suggestions how to answer this clinical quandary. And if you want to pull this article, it's very nice. So you can have, if you need to have discussions with your patients about what to do, this kind of has conversation starters, interviewing techniques, using motivational interviewing to work with patients on what to do. It provides individualized nutritional approaches that are outlined in this article, what to do, also discussions about exercise resources. But some of the things that are mentioned in this is we may need to consider medication interventions for overweight, over obesity if needed. So bariatric surgery for a CF patient, never have heard of it in the CF world, but this is something that we're now facing within this era since ETI was approved. The next area of nutritional affecting the gastrointestinal tract is acid reflux. And this is something that may be changing now as patients are on highly effective modulators, because originally, since they have decreased pancreatic bicarb secretion, it would lead to larger amounts of gastric reflux, but also they would probably sometimes need to use the acid reflux medications, H2 blockers or proton pump inhibitors, to help reduce the gastric acid, improve the enzyme efficacy, because enzymes don't like acid. And right as of the most recent data report, over almost 50% of all CF patients are prescribed an acid reflux medication. This is somewhat controversial because of side effects and long-term issues that are affected by acid reflux medications. And in the era of highly effective modulators, this may decrease, but as of right now, this is what we're seeing, but more to come on this. Fat-soluble vitamin deficiencies, as patients are not releasing the enzymes, they're having decreasing fat absorption, leading to fat soluble vitamin levels that are declining. So this can affect the A, D, E, and K vitamins. So ADEC, if you want to remember that. Also, water-soluble vitamins and minerals such as zinc are also affected because they're linked to vitamin A. So the recommendations from the CF Foundation is levels should be monitored at least annually, and supplementation is essential. And up to almost 90% of all patients are prescribed some sort of vitamin supplementation. This is what is affected by the vitamin A, vitamin deficiencies, and you can see all of these. The reasons we need to supplement is we need to prevent these from happening. So vitamin A is used in night blindness, zinc deficiencies. Vitamin D is bone and skin issues. Vitamin E and K are blood issues that we need to prevent, and that's why we supplement for these patients so we don't see these issues. So there are vitamin-specific, CF-specific vitamins that are available. So the MVW line has lots of different formulations, drops, chewables, gummies, soft gels, extra vitamin D available products. They also manufacture Genedec, which is more marketed toward the international space, but is also available from MVW Nutritionals. The Callian Pharma line is Decas. The Decas Essentials is just A, D, E, and K in a small capsule, and the Decas Plus has all the other vitamins and minerals in it. These are available through the vitamin company website, so you do not need a prescription. The patients don't need a prescription for these. They can also order from the value-added programs without a prescription. Pharmacies can fill, but I know you guys are one of those pharmacies that will do all CF-specific stuff, and you will do CF vitamins. And they can be ordered directly from the manufacturer or from the pharmaceutical wholesaler. The HealthWell Vitamin Supplement Fund can be used to bill. It provides $1,500 to cover the cost of these vitamins and the supplements. And so that's something as a pharmacy card, as a BIN, PCN group number that you guys can actually bill in order to get these covered for patients who either can't get them from the value-added program, want to get them from you instead, or if they have Medicare or Medicaid and they cannot qualify for the value-added programs. The clinical nutritional quantity number 2 relates to the vitamins. So roughly 90% of patients are on CF-specific vitamins, but now we are seeing, as of August of this year, we are seeing case reports and studies of increased vitamin levels and toxicities in patients taking CFTR modulator therapy. This is going to be a problem because, especially with vitamin A, what do we do with these patients with highly effective modulators and you're having patients having toxicities? So this is where we have the options. So you either can take your CF-specific vitamin that you're doing and modify the dosing by taking levels. However, the levels, since they're fat soluble, are delayed, and in some case reports, we're seeing patients, even though we have normal vitamin A levels, are exhibiting the toxicities of the increased intracranial pressure and having issues with their eyes. And so a recommendation, what MVW Complete Formulation has done is they've made a modulator formulation vitamin that is available as a liquid drop, as also the soft gel minis. It's specifically formulated for patients who are on ADEK vitamins and on a highly effective modulator and may have increased elevated levels of vitamin A, D, and E. The reason it is designed, it has lower levels of preformed vitamin A, which is the retinal palmitate, which just crosses right through, gets absorbed right through and crosses the blood-brain barrier, but has higher levels of provitamin A, which is the beta carotene, which is the natural form of vitamin A, which has to be converted in the body from beta carotene to retinal palmitate as regulated by the body by a need. And so this is a way to have less issues with toxicities if you do this. vitamin instead. So this is a recommendation. That's why it's available. And so if you have any questions, you can certainly email me more about it, or also MVW specifically. But the liquid drops are available as in December. They're going to be released. Um, and as the soft gel minis are available for patients to order. The next area of issues with pancreatic insufficiency is constipation and distal obstruction syndrome, or DIOS. This roughly affects about 2% of all patients, and normally is due to the ingestion of a fatty meal with not taking your enzymes. And this is what can be caused because that increase, you have the sludging, or you have the swamp in the gut, and that can cause this to happen. In order to treat it, we give them, that's why some patients are on polyethylene glycol or Miralax, also lactulose, to kind of keep things moving to prevent this from happening. The non-pharmacological things that can affect pancreatic insufficiency, we want them to follow a normal dietary pattern. That is changing based on recommendations from dietitians, is we don't exactly know if they need to have all energy foods and calorically dense oral supplements and enteral feedings, but we do know that that is recommended for younger patients who may not be on a modulator, or if they don't qualify for modulator, we still need to have them do these. Pre and probiotics are also recommended for CF patients, and there's studies that have been shown that they reduce intestinal dysbiosis, which is a abnormal gut flora in the intestines, as well as inflammation that can lead to, by decreasing these, can reduce, lead to improvements in nutritional status and pulmonary function. And some examples of these are the MVW Complete Formulation Probiotic, which has pre and probiotic available from MVW Nutritionals, Culturell's example, BioGaia. There's a whole bunch of other ones. Most of them are covered by the Healthwell Nutrition Vitamin and Supplement Grant. Liver issues affects roughly 4% of the CF population because of biliary, the increased sludge and the swamp in the mucus. Shrek is very happy, but we can kind of clear that through using medications that may be available, but that is what happens, and it can cause increased risk of portal fibrosis and cirrhosis of the liver from the thickened secretions in the bile ducts. The only medication that's available is ursodiol, or ursodeoxycholic acid. It helps thin out the bile by decreasing the amount of cholesterol in it and thinning the biliary sludging. However, it is controversial. New guidelines have been released by the CF Foundation, shows that there's no benefit for this, and it is not recommended for routine use. So a lot of patients are on it, but that might be reducing here in the near future because of the new guidelines that are being released that recommend against the use of ursodiol routinely in patients. The next area where there are medications would be in the endocrine system, and this would be the pancreas. And so with the cystic fibrotic pancreas, it can affect both the exocrine and endocrine portions. The exocrine we already focused on. Now this is the endocrine portion of the pancreas that's affected. Roughly 20% of all patients have a condition called CF-related diabetes, more on the adult side than the pediatric side. And the reason it's an issue is because it can affect weight, lung function, overall general health, as well as microvascular complications are higher in patients with CFRD, leading to issues with the eyes, the kidneys, and the nerves. So we need to treat them. The pathophysiology is very similar to a type 1 presentation, but also has issues with characteristics of type 2. But it's distinctly different because it's a reduction instead of a autoimmunity type issue like type 1. It is a destructive process from the destruction of the endocrine cells in the pancreas. It's basically marked by insulin insufficiency that can be delayed, like a type 1, but also type 2. The treatment is they need to be treated with insulin therapy. That is the only medication that's recommended by guidelines. Most recent ones were released in 2022. The international guidelines recommending insulin for patients, and over 70% of all CFRD patients are treated with insulin. Oral hypoglycemics and other non-insulin treatments are not recommended at this time, but studies are being done. So in the near future, we may see some changes in the treatment of CFRD. The last area that we'll spend the majority, the rest of the time is on the lungs, and that's where we have the majority of our treatments, as well as overall general health, as with the lungs is what we're targeting. And so with this the reason we affect most of the stuff with the lungs is what we see. 90% of all fatalities are due to lung issues and lung transplantation for patients. There's a lot of hypotheses proposed to explain the pulmonary pathogenesis, and steps have been recognized as targets for therapeutic interventions along the way. So this is the diagram of basically the proposed mechanism of pulmonary pathogenesis for the CF patients. From the defective gene in CFTR leads to the thick, sludgy swamp in the lungs, causing obstruction, airway cell inflammation, activation of those cells, infection of bugs, swamp bugs that like to live that become friends of Shrek, that live in the mucus, inflammation leading to eventual destruction of the lungs called bronchiectasis. And on a CT scan, it looks like Swiss cheese holes throughout the airways of the lungs. So the first area will be non-pharmacologic. This affects the obstruction and the secretions themselves. These are not medications, but they are things that we can do to help reduce these. So nutrition, even though we already talked about it, is very important. Originally, when CF patients were diagnosed, we tried to restrict the amount of calories they would do in their fat because we didn't want them to malabsorb. However, we found that by decreasing their weight, their lung function did not do as well. So they figured out the correlation between them. So now we've tied their weight to their lung function. We see that they are correlated together. Physical activity, we want them to be active, to do exercise. Psychosocial, we want them to have good mental health, because then they will want to do their therapies. And the airway clearance techniques that we have, these are the chest physiotherapy, usually for younger kids that can't get a vest. And then you have the high frequency chest wall oscillating systems, or the vest therapy is the most common. None of them are more effective than the other. There are equivalent according to study, but we know that if they don't do them, then they don't get the benefit. So we want them to make sure they do their vest or their airway clearance techniques on a daily basis. The next area is bronchodilators. So this affects the bronchial obstruction. So this would be medications such as inhaled beta agonists, albuterol, levoalbuterol. They're short-acting, your longer-acting ones, as well as inhaled anticholinergics. The mechanism of action opens up the airways and allows the air to move through better, and then the medications to get in there and help work better because they're able to pass through the lungs and into the mucus. Over 90% of all patients are on inhaled beta agonist, regardless of age. Less than 5% are usually on inhaled anticholinergic. The reason being is because of the level of evidence. The guidelines actually recommend against the chronic use. There are insufficient evidence for or against the chronic use of chronic daily bronchodilator therapy. However, patients are doing the bronchodilators to kind of alleviate the symptoms, as well as to help pre-treatment for the side effects that can happen from the other medications. So we do want them to fill these on a monthly basis. Different than asthma, where if they're filling the bronchodilator, you want to see if their level of control is there. This is one where we want them to do it because it's part of a chronic regimen for the patients. The mucolytics, so hypertonic saline, Dornase alpha, and helmannitol, help clean out the mucus, thin it out. So these are kind of the anti-Shrek medications, anti-swamp, to kind of keep the mucus thinner for the patients so they can breathe easier. Hypertonic saline, so there's different varieties available that you will see. There's generic, there's brand names of them. All of them work the same way. They increase the amount of sodium in the airways, thus put water from the lungs into the airways to thin it out. They were developed, the concept was developed back in Australia when Australian surfers, the doctors noticed that their lungs would improve if they had increased, after they went surfing, their lung function improved, and they did studies to show that this does work. So water does follow salt to thin out the mucus via osmosis. It's a science experiment for these patients. Over 70% of all patients are on this in the older patients, less in the pediatric population because of study. The dosing is twice a day. It's a pre-filled nebulizer, ampule for nebulizer, and they're available different strengths, 7% being the most common. The recommendations, it does improve lung function, keeps people out of the hospital. The most common side effect is bronchospasm. So you need to pre-treat with albuterol, levobuterol prior to doing the hypertonic saline therapy to prevent the bronchospasm in these patients. Some tips for you guys in specialty pharmacy. One of the things, it's considered medication. Not a medication, it's a medical device by the Center for Medicaid and Medicare Services. So some state Medicaid insurances will not cover it because it's considered a medical device. So you can bill it through charitable organization grants, such as the Health Well Treatment Fund, which currently is closed, but I was told it's going to be opening up in December, January time. So that is something that can be used to bill directly to for those patients instead of right through the primary insurance. So that's one tip of the hypertonic saline to remember. Dornice alpha. So this is a mucolytic. It acts like Pac-Man. So Pac-Man, working against Shrek, working for Lord Farquaad to break up the mucus. So it chews it up and makes it thinner. This is the most commonly prescribed medication outside of modulators for patients. Roughly 90% of all older patients are prescribed this, less in the pediatric population. However, it is FDA approved for all patients regardless of age. The package insert changed. Used to be FDA approved over 5. Now it is for all pediatric population regardless of age. It can be given once a day, twice a day, in the package insert as one ampule once or twice a day for the patient. It improves lung function, keeps people out of the hospital. Side effects are pretty well tolerated, mainly with voice alteration and things with the throat, laryngitis, and other issues that can happen with that by inhaling a medication. Specialty pharmacy tips for you guys, because you will be prescribing this for dispensing this to a lot of patients. It must be stored in its protective foil pouch under refrigeration. So when it's shipped, has to be protected from light and also heat. One of the things that is available, you may get calls about this. What if they leave their pulmozyme or their Dornice alpha out of the fridge overnight? What do we do with it? It's still good for 24 hours as long as it has been protected from light. At room temperature is fine. They can put it back in the fridge. But if left in a hot car on a hot day, that's totally different. It's probably destroyed. But if it's left out at room temperature, it's still good and that can be put back in the fridge. It's considered a specialty medication, so it must be filled at the contracted specialty pharmacy. Prior authorizations are usually needed. If they need help with their prior authorization, if it's not being approved, you can submit the package insert to the insurance, and usually that will help with coverage with pediatric patients as well as a twice daily utilization. And that's just a tidbit that we found at our clinic that the package insert helps quite a bit with the new changes with the package insert. Inhaled mannitol, this is more for the adult population. It was released just a couple years ago. They don't know exactly how it works, but they think it works very similar to hypertonic saline by pulling water from the lungs. It is dosed 10 capsules twice a day. They have to like a tolerance dose prior to starting. There is a copay assistance available, but the utilization is very low because it has just been released not too long ago in the era of highly effective modulators, so not as many patients are on it. Copay assistance programs, the Dornice Alpha program is available as a copay card. One thing that you guys can do if you're not doing it now is you can actually go in and sign up for a portal to track your patient's copay assistance information. So you can sign up. Care teams can do it, but also specialty pharmacies can do that on this website here, and you can actually get that information and track their copay card information if they transfer to you, but also how much they have left on the card. It allows you to do that. There also is a program they can get it directly if they do not have insurance. The next area is the infection, and I put it as green because we're affecting, as antimicrobials, we're targeting the swamp bugs, and Pseudomonas is green, which is the main one we're targeting, and that's why I put it there, because they love Shrek. And so the first one is inhaled tobramycin, and this is available in all different formulations, generic. There's a branded generic by Catavaspac by Pari, and then the Toby Podhaler, which is a dry powder inhaler. All of them are aminoglycoside antibiotics that target Pseudomonas by affect its ability to make proteins. 60% of all patients over the age of 6 with Pseudomonas are prescribed this, not as much in the pediatric population. The dosing is down here, but the nebulized tobramycin is the same dosing. The Toby Podhaler is a little bit different dosing, but they are equivalent by study in how they kill Pseudomonas. They both improve lung function, they kill the Pseudomonas, and they keep people out of the hospital. The most common side effects are cough and dysphonia, especially with the Toby Podhaler. One of the things that teenage girls do not like using the Toby Podhaler because of dysphonia. Teenage boys think it's cool to sound like Darth Vader when they're on the Toby Podhaler, but teenage girls don't seem to like that, so they prefer kind of the nebulized tobramycin instead because of that. Specialty pharmacy tips for you guys. The nebulizer must be stored under refrigeration. It's protective pouch. However, it's good for 28 days at room temperature. The treatment is for 28 days. So the clock will start ticking once you leave it out. If you put it back in the fridge, it resets the clock. So that's just something to be aware of. The Podhaler must be protected from moisture because it's a dry powder inhaler. With the prior authorization, one of the things, most of the patients, a lot of insurances don't want to cover the Toby Podhaler at first. So a lot of times they have to demonstrate a trial and failure of the nebulized tobramycin first before they will cover the Toby Podhaler. That's just a tip that we found at our clinic. There are copay assistance programs available for all of them. The one product called Bethgis that used to be on the market is now generic, and so Teva has a copay assistance program for that product, and as well as the other ones are available here. Inhaled aztreonam, you're one of the special few pharmacies that actually get to dispense this, so I'm going to cover a little this for a little bit for you guys. It's a monobactam, so it's similar to a penicillin derivative that targets Pseudomonas by inhibiting its ability to make the cell wall. It's not as much prescribed as nebulized tobramycin, probably because of the FDA approval and insurance coverage, as well as the 3 times a day. So there's kind of some issues with it. It's very few pediatric patients are on it under the age of 5. Less than 40% in the older patients. Its FDA approval is 7 and above, and the dosing is 3 times a day via the Casein Altera nebulizer. So there are some issues with this that are specific for this product that kind of either limit its ability to be prescribed or of just getting it for the patients. The benefits: improves lung function, keeps people out of the hospital, kills Pseudomonas, and the side effects are very similar to the tobramycin, cough being the most common. The tips for you guys is like the 28 days is still there. So it can be refrigerated longer, but for 28 days, that clock will start ticking at 28 days if it's left out. You are part of the 7 licensed pharmacies that are able to distribute it, and prior authorization is usually required. And we've had a lot of denials for patients under the age of 7 that we have to appeal. So that's something that we have to worry about. The tips on the PARI, I'll tell you, nebulizer system. So this is one thing that can be an issue. The first dispense for every patient, they get the Altera nebulizer system dispensed with 2 handsets, and that is free from the company. And the case and assistance program provides that approval for you guys, and then you're able to dispense it. After that dispense, they only get 1 handset dispensed with the medication. And this is for the lifetime of the patient. So if they go off it for a while and then come back on it, they will not get another free Altera nebulizer system, and they will not get 2 handsets at once. You only get 1 after that. The warranty is only good for 2 years plus a 1-year extended warranty. If the patient restarts it, that 1 handset is all you can do per fill. If they need additional handsets, they either have to purchase them through Nabology.com. Sometimes you can get Healthwell 2 cover and the Altera nebulizer system, just not the handsets themselves. They usually have to buy them from Nabology.com specifically. There is a manufacturer coupon available for some patients to get half off on the nebulizer system, but they will have to pay the other part of it or purchase it from Nabology.com for roughly about $1,000 for that unit to be purchased. So you guys are part of this Case and Access Program Network. This is the copay assistance program. They work with you to make sure that they can get everything's dispensed and ready to go, and does provide the copay assistance for the patient. Inhaled cholistomethate sodium. This is not FDA approved right currently as a inhaled medication. It is a IV that's given as a nebulized product. Not as many patients are on it, and that has declined over the years because of the highly effective modular therapy. But if they do this, the patients actually like it. It does taste like burnt marshmallows, kind of like a s'more. And so the patients tolerate this quite well. Inhaled amikacin. This is a medication that you're one of the pharmacies that are able to dispense this. It is a aminoglycoside also that affects the ability to make proteins. It's not FDA approved in CF. It's FDA approved in adults with Mycobacterium avium complex. So patients who have CF can get this. Just that's not one of the only. They have to have the Mycobacterium avium complex in order to be for the approval of the package insert. But it's been studied in Pseudomonas as well as a Mycobacterium avium complex in CF. The dosing's once a day via the Lamira nebulizer system. There is a copay assistance program, and the most common side effects are usually cough and things with the lungs. You guys are part of that limited distribution. One of the 2 pharmacies that can do this. This is the copay assistance program available, and usually prior auth is available. And we have been able to get it approved for pediatric patients with usually some documentation, but this is just some information for you guys that it can be stored room temperature up to 4 weeks. Very similar to the other things. Because of that clock can be ticked, but it can be put back in the fridge. Anti-inflammatory medications. So these are the ibuprofen, azithromycin, as well as leukotriene receptor antagonists and inhaled corticosteroids. They affect the inflammation. Ibuprofen was studied in the pediatric population. We don't know how it really works. We just know it decreases the inflammation and can reduce the migration of inflammatory cells to the site of action. Adults, it didn't really show any evidence, so we don't know if it's used or not, but the utilization is mainly in adults. Most pediatric patients do not use it because they use it in favor of doing azithromycin, which is an antibiotic, but has anti-inflammatory effects. And so if you see azithromycin Monday, Wednesday, Friday for a patient. This is what we're doing it for. It has anti-inflammatory effects. It mainly is prescribed for patients who have Pseudomonas in the older population, not as much in the younger population. We do know it improves lung function and keeps people out of the hospital. We just don't know exactly how it works, but we do know it does. The leukotriene receptor inhibitors, which would be montelukast or zofrelukast, they're not recommended by the CF guidelines. However, quite a few patients are using them. Inhaled corticosteroids, if you see a prescription for fluticasone or mometasone, they're actually recommended against its chronic use in CF patients unless they have asthma or a condition called allergic bronchopulmonary aspergillosis. So there are a lot of patients do use them, but they need to have some sort of documentation or they will need to be pulled back. And we're hoping the trend is to pull these back, but still patients are on them mainly for asthmatic component of their airways. The pulmonary clinical quandary that we're seeing now post 2019 is a decline in the prescriptions for and the utilization for all of the major airway or pulmonary medications, antibiotics, as well as hypertonic, Dornier alpha, and azithromycin. And the reason being is the highly effective modular therapies that we have. There was a survey that was done just earlier this year of patients with on CFTR modular therapies as well as their providers that showed that over 1/3 of parents of children, over half of adults are doing fewer treatments, and over 10%, 13% of adults actually stop their airway clearance techniques. And over 50% of CF providers have decreased their plan they're using of what they will do, what they'll recommend for patients who are on highly effective modular therapy. And the reason for this is we actually have a study. The patients are feeling better, and so they actually did a study called the Simplified Trial, which was published earlier this year. Because they showed there was no difference in the lung function in the discontinuation versus the continuation group for both medications. In fact, patients with Dornier alpha actually did worse if they continued the Dornier alpha instead of stopped it. It wasn't statistically significant, but it showed that they did worse. There were no major adverse events occurred. However, patients with lower lung function had more adverse effects of cough and nasal congestion when the therapy is discontinued. So in patients with not severe lung issue or have normal lung function, they showed that they in the short term, they may be able to stop their therapies. And so this is something that is coming out there. So what are we going to do with this? Especially the specialty pharmacies and clinics, when you face this question, how do we address this? So more studies are needed to show the long-term effects of lung function. And just recent published this year that shows that we can actually what is a kind of a trend of matching what people are actually doing. So this study called the Simplified Trial was published that was done to show patients who are on highly effective modular therapy if they can discontinue either their hypertonic saline or Dornier alpha. The results of that showed there was no difference in lung function, either continuing or discontinuing hypertonic or Dornier alpha. In fact, patients who continued the Dornier alpha actually had worse lung function than those who did not. So one of the things that from this, no major adverse events occurred except for those who had lower lung function that had more instance of cough and nasal congestion when the therapies were discontinued. So the recommendation from the study was that you can discontinue in the short term. We actually can discontinue either of these therapies if patients are on highly effective modular therapy with no major events occurring. So what do we do in this case with the people who are stopping their therapies. We have results from that. We also have a clinical trial showing that we can stop. We now actually have some information to look at that. But more studies are needed to show the long-term effects on lung function for those who are decreasing their airway clearance therapies on highly effective modular therapy. We know patients are doing it on their own, regardless of study results. So as care teams, especially alpha or the hypertonic saline, and patients are saying, I don't need them anymore, you need to ask that, what's going on. And a lot of them will say their lung function's improving, and it's probably correct because of what we're seeing and the studies that we're showing. However, it's currently not recommended, but things are changing as more and more studies are being done. So the last area we're going to talk about, the CFTR modulators. So there are 4 modulators on the market. All of them have ivacaftor as a component. And all of these therapies all affect the overall general CF pulmonary breakdown, but they also affect other organs of the body. But we know the lungs is the most effective because they target the actual cause in that CF gene defect that's happening. So the first one that was FDA approved was ivacaftor Kalydeco back in 2012. 6% of all eligible patients are prescribed this up to age 1 month is now what's FDA approved for over 97 different mutations that have at least 1 copy. How this works is it works on the classes 3 through 6 mutations. So it targets that rusted lock and fixes it to make it into a pristine lock. So as the ivacaftor comes in, it makes that lock like you would buy it from Home Depot, the very expensive lock that very works. It helps move all the downstream effects. It helps fixes everything to take that sludgy mucus away and make it into the thin mucus for those patients and having overall general effect at improving the overall general body. And this is Lord Farquaad on steroids to help make sure we get rid of Shrek. So the benefits of it: improves lung function, keeps people out of the hospital. The most common side effect is headache and abdominal pain. Those are ones that we're seeing, but they're very well tolerated from a medication. Monitoring, this is for all the CFTR modulators. They have to monitor their their liver function quarterly for the first year and then annually after that, as well as annual eye exams, baseline and yearly, only in the pediatric population because they saw that cataracts could form in pediatric rats. And so the recommendation is for all pediatric patients to have this monitoring, but adult patients do not. The next one, Lumacaftor ivacaftor, was approved in 2015. It's for ages 1 year and above for the F508del homozygote patients. Right now, only 4% of eligible patients are prescribed this because other medications have come out, but this is still down to 1 year of age, and patients can use this. This goes in and fixes the underlying defect of the channel. So it goes in, makes that so the channel is there. It's not, I would not consider this a pristine lock from Home Depot. It's probably one that's you would get probably at Dollar Tree. It's not as effective, but it does work at kind of stabilizing the lungs. It does improve chloride channel improvement, and water attraction. Also takes the thick mucus and does thin it out. Not as much, but it still works for these patients. The benefits: it improves lung function about 2 to 3%, does keep people out of the hospital. The most common side effects is dyspnea. So in patients who are taking this, it actually can cause their lung function to decline after they take this medication. So it is something that it's not as effective, but does work at stabilizing the disease. Monitoring is the same as ivacaftor. For tezacaftor, ivacaftor, this got approved in 2016, 2017 for patients. It's FDA approved for 2% of the eligible population right now, are actually taking it. That's for 154 different mutations, including the homozygote F508del for patients 6 and above. Its utilization is not as much because of ETI coming out kind of supplanted this as a medication, but we still have patients who are taking it. This one does affect classes 2 through 6. For the class 2, it is not is a little more effective than the Lumacaftor ivacaftor. For the 3, 4, 5, and 6 mutations, actually works quite well, sometimes even better than Lumacaftor by itself. So it does have some benefits. So when the medication comes in, the combination comes in, it does fix the underlying defect and improves the lung function, the movement of the chloride ions, the water traction, and the thick mucus making into the thin mucus, especially in the 5 and 6 mutations. It can actually make this very thin and very effective for those patients. Improving lung function, overall, the percentage is like 4 to 7%. A little higher in the patients who have the less severe mutations. It does improve pulmonary exacerbations. Side effects are very similar to ivacaftor. Headache and abdominal pain, nausea are the most common that are reported. Monitoring is the same as ivacaftor, and the drug interactions are also the same as ivacaftor. Very few drug interactions with this medication. The most effective and the most commonly prescribed now is elexacaftor, tezacaftor, ivacaftor, or ETI. Over 2/3 or 3/4 of all eligible patients are prescribed this. It's now FDA approved down to age 2 years as of May, June of this year, including the F508del, with you only have to have 1 copy. This medication is the ultimate Lord Farquaad at getting rid of Shrek out of the swamp for the class 2 through 6 mutations. It fixes the underlying defect quite well, and that pristine lock would be one that you would get at Home Depot, very expensive, improving the chloride ion movement, water attraction, and making the pristine swamp into the thin mucus. We have an example of this. So I had a patient who started it after about a week in the hospital. We started the medication when it first came out, and her mucus after 4 days went from thick, sludgy to nothing. Just looked like spit. Very clear mucus for the patient. It was only 4 days. So very, very effective and very, very quick onset of what it does. It does improve lung function the best, up to 14% improvement in lung function, keeping people out of the hospital. Side effects very similar to ivacaftor that are reported in the package insert. However, we are seeing now some behavioral side effects, some brain fog, anxiety, sleep, insomnia that are not reported on the package insert, but there are case reports and case series about it. So we're more to come on that as more and more studies are done. Monitoring the same as ivacaftor, and the drug interactions are very, very similar to ivacaftor. Very few drug interactions for this medication. The copay assistance program that's available is the Vertex GPS. You're part of that specialty pharmacy network, so they insurance and providing that copay assistance, which has decreased since January of this year. And so there's a little bit more on the next couple slides about that, but this program does help those patients to get their medications. Some specialty pharmacy tips. So these are some things that you may see with your patients. Some questions. The ivacaftor granules for pediatric patients can be administered on soft food, put in applesauce, or mixed in an oral supplement or milk to be given within 1 hour. So that's something that you can do. The Lumacaftor ivacaftor granules are very bitter. When this first came out, we did not know they were bitter. We contacted the company, said, oh, no, there's no issues with it. And then finally they admitted, and it was released, that there is some bitterness to the Lumacaftor ivacaftor granules. So mixing it in something that's sweet or rich, like caramel sauce, melted ice cream, does help the tolerability with those granules. The ETI granules are very similar to ivacaftor to administer, but they're a little more grainy. So the texture of it is a little different than ivacaftor. So the child may not have tolerate as well. It may be an issue for those kids. So that's just something to be aware of. It's a limited distribution network, so you're one of the 6 licensed pharmacies that can do that. There's also some health system-based pharmacies. They're able to get it through McKesson Biologics, so that is something to be aware of, that if you're filling medications for other patients, they may be getting the modulator from another pharmacy. From the copay assistance change as of January 2023, you can find the information on their website. It is an issue to patients right now. There was an article that was published in Pediatric Pulmonology earlier this year looking at this issue that people are facing. People are running into issues because they're running out of copay assistance money, especially this time of year. And as they're going into the new year, that is something to be aware of because they only get $20,000 a year. And so they may need to find alternatives for accessing the medication. So you can refer them to CF Compass, CF Foundation Compass, or Vertex GPS. The Health Well Foundation Grant Foundation CF Treatment Fund was an option, but as of July this year, it has been closed. It will be opening up in January, but for limited time. So that's just something to be aware of as facing this, that this is the biggest issue that people are facing right now and a source of frustration for our patients. So the quandary that we face with the CFTR, now we have up to 91 of eligible patients or age of 2 are prescribed CFTR modulator therapy, and the median age has increased up to age 56. We're seeing improvements in lung function, body mass index. Most adult patients now have a normal lung function. It's almost 90% of adult patients have a normal lung function. And we're seeing more pregnancies than we ever saw before. There's an increase in the pregnancies up to 634 pregnancies, almost over double during the era of highly modulator therapy. And due to this, we're now seeing reports of CF patients giving birth to CF babies. There was a case report that was published in 2021. There's also a case in Utah that I'm going to go through that is a new that we're seeing that we this. So the health trajectory has changed. So you are going to be facing more and more questions as a specialty pharmacy team taking care of these patients. And one of these questions may be similar to this. So we had this case in Utah where it was a patient that I had taken care of as in clinic, moved to the adult center, and then she had a child with CF. She was on ETI during the entire pregnancy, and the newborn screening came back F508 homozygote. When the child came to clinic, they did not exhibit any CF symptoms for several months. The patient was initially pancreatic sufficient. The patient weight at birth was about 9 pounds, and by the time at 7 months, when they finally started exhibiting symptoms, was up to 30 pounds after 7 months. So it took that long for the patient to become symptomatic, requiring enzymes, vitamins, and inhaled therapies. So this is something that we're now seeing, that you're going to be getting questions about this in this new era of highly effective modular therapy. And it's only going to get continuing as more and more patients get on it and the age gets younger and younger and younger. The drug pipeline. So this is something from the CF Foundation that they develop this and they maintain this, and you can look at it every day. It's routinely updated and anyone can access it. And there's different areas and they show where things are being developed. And I'm just going to highlight a few of those things for you guys so you know what's coming. There are medications that target genetic therapy. One of them is a Vertex medication that is in phase 1 clinical trial. That would be almost like a clinical cure for all patients. So that's something that is coming. There is a new CFTR modulator called vanzacaftor, tezacaftor, duditacaftor that is currently in phase 3 studies and projected to be approved in first quarter of 2024. And you would be one of those pharmacies that would be dispensing this. So that's something to be aware of. They only have to have 1 copy of 508 Del, and it is once daily instead of twice daily. So issues that we may face with that in terms of dose reductions, for dose modifications for liver issues and tolerability, that's going to be an issue that we're going to face. So that's just something to be aware of, that this is in the pipeline. There's more anti-infectives that are in the pipeline, including inhaled cholestyramine sodium for U.S. patients that will be FDA approved, as well as non-porcine derived enzymes. Pancreatic enzymes are in phase 2 study. So that's something to be aware of, that these are medications that are coming down the line that you would be one of those pharmacies that would be dispensing. So the conclusions. So CF is a very complex genetic disorder. Hopefully you've seen that. Treatments exist to alleviate symptoms and modify the disease process. This complexity of these medications to treat and alleviate symptoms has dramatically increased. And we're seeing this with all these clinical quandaries that's happening. There's complexities that we've never seen before. So you guys play a key role in improving the care of the patients. Hopefully you realize that. And thank you for all the work that you do at taking care of our patients and getting them their medications and answering the questions. And hopefully this training is helpful to provide some of that information. So this is my contact information. So if you have any questions, you can reach out to me. This is my email address. Also my direct phone number. If you have any questions, you can reach out to me. And at this time, I'll entertain any questions. Thank you.
Thank you, Jeff. That was really great. I appreciate it. Just one question, and I know we didn't talk about this, but I'm just curious your thoughts on it. As it relates to opportunistic bacterial infections like Pseudomonas, with these highly effective modulators, do you anticipate that we're going to be seeing the usage of those decline?
Yeah, I mean, so it is highlighted in that where we're seeing the number of, in that graph, that clinical quandary where you're seeing less Caistin, Astrinam, Tobramycin prescriptions. One of the things that was been seen in some of the studies initially with ivacaftor, and also there was a study that was just done with tezacaftor, isacaftor, ETI, showing that patients clear the bacteria initially because you're clearing out the bacteria and the mucus, and we're seeing like people eradicate, right? They get rid of their Pseudomonas early on, but then it seems to come back. But the question then is faced is, do we need to treat them at that point? Even though they are colonized with Pseudomonas, because it lives in the sinuses, I mean, it probably just comes back down, but their lung function is totally improved. So in our experience in our clinic, what we would do is we would assess them before they would be on like continuous cycling. They'd be on tobramycin 1 month, Caistin 1 month, and they'd be just rotating.
Right.
And then we found that some of those patients, if they were continuing to take their modular therapy effectively, that we could probably stop the inhaled antibiotics. And so I anticipate as more and more, as the vanzacaftor comes out, you're probably going to see less prescriptions for the inhaled antibiotics. You're going to see it more in the patients who have more severe disease, because there are some patients who, even though they're on modular therapy, they're still getting sick. They're still getting hospitalized. And so there is going to be a percentage of patients who are going to need it. But I think in the ones that have better lung function and they're better tolerate, having, overall better effect, you're going to see patients using it less and less than they would before.
Thank you. That's exactly what I was wondering and getting at, because since they are opportunistic and these patients now are doing so well, and we all have this, I'm interested to see what the future looks like.
Right, because we have several patients who are doing well, right? I mean, we have some who are not doing their therapies at all, and their lung function's improving. And so there are some patients who, now they got to take their modulators all the time. We have some patients who are stopping their modulators or not doing as much. And so they're just more, there's got more studies have to be done to see what needs to be done. But I think a good percentage of the population may not need to do their inhaled therapies, but that has to be teased out by the CF Foundation. But I think the CF registry report that comes out The new one that comes out, you're going to see even a far further decline in the medications, the prescriptions for those inhaled therapies, antibiotics, as well as the mucolytic therapies.
Interesting. Great. Thank you. And then the other question I had was related to pregnancy and CF, and particularly the mother who's giving birth to a baby with CF. Are there any further studies being done to see if the CFTR modulators are being produced or being excreted in the breast milk? Part of me wonders if that is having any effect. I know I didn't see any information about it, and I didn't know if you had any additional information.
Yeah, so there are actually some studies that have been done. There was one that was published last year about excretion in breast milk. So we do know that ETI does get it crosses the placenta in a large percent, like 90% of it processes the placenta, as well as 90% is excreted in breast milk. So we do know that it can. That's why babies that are born, the one case report that was published in 2021, that baby actually was newborn screen negative and was.
Oh, wow.
So wasn't even picked up on newborn screen. Our baby in Utah, the newborn screen showed it's called the immunoreactive trypsinogen was elevated, but was like slightly elevated. So it picked it up, but it was because also the newborn screen in Utah does genetics as well. So we knew what the genetics were. But if you saw the baby, you would say that baby doesn't have CF. In fact, for 7 months, we were sitting there going, this baby is CF, but what's going on? And so they've done some studies, and there's actually another report that was done that showed that babies who were born to moms of CF, but the babies didn't have CF, were having issues with eyes, that it does cause cataracts because it does cross the placenta, and babies being born with they're breastfeeding them, that there were issues with eye issues with the babies being born, healthy babies being born to moms with CF. So it's kind of a catch-22, right? So the babies being born, they're healthy, but they may have issues with liver. The liver enzymes may go up because our baby in Utah had elevated liver enzymes. And so it's not safe, right? You don't want to pull the mom off ETI because that's what's keeping her healthy so she can have the baby. There's another report out of Stanford where they actually healthy mom, but mom was going to have a baby with CF, so they actually gave the mom ETI during pregnancy, and it caused the baby to have its meconium ileus reversed in utero. And so there's reports of, okay, let's give ETI to every mom that would prevent CF from happening and the baby not being born with CF. However, that's again a very controversial area because now you're giving a drug that does have side effects to a mom. So there's a lot of beat reports out there of ETI in pregnancy. We do know that it does cross the placenta. We do know that it goes in breast milk. So we actually told this mom to not breastfeed because we didn't know what was going to happen. We thought that the baby would reverse pretty quickly because the half-life is about 3 days, but that's the drug pharmacokinetic half-life. The pharmacodynamic half-life, we don't know. It took up to 7 months for this baby to have a positive sweat and to exhibit symptoms. So we don't know there's got to be more studies done. They're actually doing a study called the Mayflower trial, and initial results were given at the CF meeting, not much, but they're talking about because they're looking at pregnant moms on Trikafta. What does that do to the babies? And the Mayflower trial will probably tell us more information about exactly what we're going to see in this population with pregnancy and lactation. So more to come, but that's a question that we're going to face. Pharmacies are going to face, teams are going to face, especially as more and more pregnancies happen and people live longer and it just, and more drugs come out. This is something we're going to face more and more here to come.
Absolutely. I appreciate your insight. Thank you so much.
No problem.
And thank you for a great presentation. Those are the only questions that I had.
Okay.
But
all right.
I will definitely share as they come up. So thank you, Jeff, very much.
No problem. And so what I'll do is I'll send the slide deck to you guys so you have it, and so you can use that and reach out to me if you have any other questions, and I can provide that information to you. Thank you.
Thank you, Jeff. I really appreciate